And just when you think that our conference cannot get more exciting, more prestigious, it actually does, because we're about to have a fireside chat with Dr. Fernando Torres Gil, and he's one of these folks of many parts. Let me introduce him to you just in very quickly, because there was so much to say about Dr. Torres. He's a professor of social welfare and public policy at UCLA. He's the director of UCLA's Center for the Policy Research on Aging. He worked under President Carter and Clinton and Obama, and we will be talking about that. Very notably, he was the first Assistant Secretary of Aging. Do you know that we have an Assistant Secretary of Aging in the national government under Health and Human Services? Well, we do, and he was the very first. And he's now toiling in my adopted state of California. We'll be speaking about a lot of his credentials, but let me start by thanking you for being with us today, Dr. Torres. I'm so happy about that. If you were unmute. You know, I do know your background, and it's a fascinating background of being one of 9 children, part of a family that was seasonal farm workers in California, eventually having a single mom, as I did a little bit before it was cool to be a single mom. But it seems to me that emerging from this great story is a heroine, and that is your mom. I'm going to ask you a question about this and start with this. We are looking for health equity for all people. Your mom had a talent, seems to have had a natural ability to navigate the healthcare system, get you into Shriners, you had polio, get you into the right schools, have you homeschooled. How did she do it? And is there something that we can learn from her attitude that we can bring and make part of public policy so that everybody could have her know-how? I'm very impressed by this, and I think there's something to be learned here that may come from your childhood experience and watching her, even more than watching the great politicians and thinkers that you've been working with.
Thank you so much, Adriane. I hope I pronounced your name properly. And thank you for having me with you and these just amazing and notable individuals that are going to be participating. And thank you for that question. And yes, as you described, my biography of sorts is about being raised at a time when I was one of 9 children raised by a single mom in public housing on welfare, what was in the old AFDC program, Aid to Families with Dependent Children. And firstly, it was a different time and environment. This is back in the last century for younger persons in the 1950s, 60s, 70s. And things were different, but some things, though, I think, based on your question, are very useful. My mom is what we now would refer to as a care coordinator and health advocate, care coordinator and health advocate. We didn't use those terms at that time. Since she had all these children and one with severe disability, in my case, polio, she had to somehow figure out whatever that system of public benefits, services, community programs, service clubs.
Right.
But she was smart, ambitious, and focused. And although she did not have more than a 6th grade education, she figured it out. She was able to get me into Shriners with all the pro bono health care and medical care. She was able to get me on the Medicaid program and the various other programs that were available. And not just on the public benefits, but also to connect us to the service clubs, Rotary, Elks Lodge, for example, that gave us other benefits, whether it was mentorship or taking us out to get clothes during the holidays. And she connected us to the public agencies, the Housing Authority, the Welfare Department, and she befriended the social workers assigned to her. So she put it all together, but she was also an advocate, not just for her children, but for the entire community, organizing the other single mom and dads in the public housing project, chairing the Housing Advisory Committee. Ultimately, she was so smart about these things. She was hired as a social worker with the Monterey County Department of Social Services and retired, heading up the General Assistance Program. Fast forward to this day, she's recognized in Monterey County, Salinas, with the community center named after her, the Maria J. Torres Gil Community Center. So that was the background. What can we learn from that in terms of that day and age? Back then, there were robust public benefits. They were relatively generous. Second, there were many service programs that were available and were connected. And third, there was a level of cohesiveness in our community where parents could discipline other kids' parents. We thought nothing of spending the night in somebody else's house if we happened to be in another part of the neighborhood. So it was a different environment, and we're grateful that we came through that. One of my goals is how can we recreate some of the positive aspects of that time?
So of course, she was like a one-person navigator system. And I know that you've worked very much on the federal level, but I'm going to bring you down to the states for one moment here. We do have people that are not as empowered. We have disparate communities. We have people that feel isolated and alone. And no matter how many entitlement programs we give, they can't find them. And so I'm wondering, you have worked on the national level, and particularly under the Obama administration, everybody, I think, in the field of aging is a little bit jealous of what's gone on in the field of disability because they've been real advocacies and they've made a lot of inroads. But in the state of California, there's a state movement. Do you feel, because we're so interested in having our scientific breakthroughs be available to everybody, do you think we're missing the boat when we continually talk about the federal level, when actually California is working on the state level? Do you see an inroad there, particularly for the underserved people who might be more able to go to programs that are on local and state levels as opposed to federal programs?
Well, let me first emphasize, it is not either or. It's not either local, state, or it's federal. You need all of them. The reality is, in the last 30, 40 years, the federal government, in terms of its social safety net, all the many benefits that fall within that for young and old and disabled, have deteriorated. And that's why I think, not to be partisan, this administration wants to rebuild that social safety net. Certainly, state and local governments have a crucial role. In California, I believe we're moving towards dealing with the fragmentation of the many different programs that are available, trying to better coordinate them so that it's not individuals having to be the navigator, as my mom did so effectively. Many can't do it for whatever reason. But I would like to say this. I feel really proud of California. It sounds like your adopted state.
Yes.
Working closely with Governor Newsom on the master plan on aging, which is attempting to not only look ahead to the aging of California's population, but also to integrating services for persons with disability. We've injected concepts that I think are part of your conference. First, the equity lens. How do we address the growing diversity? But the other is healthy aging and intergenerational connections. How do we move beyond just responding to those over 65 or those with a particular disability and begin to invest in younger population so that they can have whatever it is that they will need for not just healthy aging, but so that they can increase their chances they'll have a longer lifespan with fewer chronic or cumulative diseases and issues that arise from the issues of low education, poor healthcare, poor nutrition, lack of exercise, etc. So I think in California, we're starting to inject some of the concepts that you're presenting, whether it's healthy longevity, the equity lens, intergenerational, and most importantly, investing in the ability of younger populations to have a healthier lifespan. So yes, states are important, and so are local government, but the federal government needs to come back in a much more stronger role as it used to back in the last century when I was growing up.
So, we talk about futurism and how things might be better now, but I do see what you're saying, that because things were simpler and because people felt more empowered, I think, locally, regardless of who they were, we may have to go back to the future a little bit. And before I throw this over to Thomas for a very different kind of question, I just want to round this out. So you are vice chair of the National Council on Disability under, I think, the Obama administration. And there is a lot to learn. There's a lot to learn for, say, the aging community or aging advocates from those who were advocating for the disabled. Is there a difference? Because of course we all grow old, but the disabled can call themselves minority. Is that a difference that makes it impossible for us to emulate some of their gains, or can we learn something from them?
Obviously, we can learn from the various groups, whether it's persons with disability or older adults or ethnic racial groups or the various other social movements. But a few words about disability. Firstly, I think it's helpful just to step back. Historically, since the 1970s, we've created two different sets of federal and state programs. One for those that have some type of disability and one for older adults. I felt very proud to be working closely in the Obama administration with HHS, with the White House, with the National Council on Disability. And what we did finally was to begin to bring together the various programs serving persons with disability, the programs for those that are over a certain age, older adults, and whatever home and community-based long-term care services might be available at the federal level. So we have created and begun to integrate at the federal level the various public benefits so that whether you're a 25-year-old with a disability or a 75-year-old with mobility limitation, you can begin, at least at the federal level, to go to one federal agency. And I feel proud to have worked on that. But in terms of disability, let's also keep in mind it's a highly diverse group, whether it's cognitive, visual, hearing, physical, emotional. There are many types of disability, but we can learn a lot from the disability rights movement and their emphasis on independence and having some ability to dictate, empower themselves for what they feel they need. And I feel that's what I got as a younger person with a disability. And hopefully we'll better coordinate programs for all of us, regardless of age, that have some type of limitation or need.
You know, one of the things that I will tell you is that working with that group myself, these are loud and proud people. Yes. And they are aggressive. And I think that we can learn an awful lot about them from attitude alone. I'm going to throw this over to Thomas because he has a provocative question that he likes to ask about whether if science helps with everybody being able to live longer and healthier, if that itself will create equity. Thomas, go right ahead with your question.
Thanks, Adriane. Fernando, first of all, thanks so much for being part of the program. It's a great honor to talk to you. I just want to sharpen a distinction. I think a lot of folks have been thinking for a long time about how to help people age well, age better. And that encompasses really important things like disabilities and equity, fair treatment for the elderly, long-term care, all those things that are very, very important. In our mission, I guess, of the Kitalys Institute, we're looking at healthy longevity for all. That is to say, extending lifespan to the extent scientifically and medically possible, while filling it with as much health span as possible. So it's a little bit of a distinction. And I guess the question I have for you is, as an expert, first a student and an expert now in aging generally, how do you react to the claim that we have, or a conjecture that we have, that healthy longevity for all is directly targeting one of the root causes of health inequity by getting to the differential access and differential treatments available for the disadvantaged when it comes to healthcare? Are we onto something, or are we sort of drinking Kool-Aid, if you will? Is my question clear?
Not totally. If you're referring to the role of science, and if you can differentiate what type of science.
Well, specifically, emerging geroscience in recent decades have suggested that we can live longer and we can live more of it healthy, free of debilitating diseases. Now, right now, it's going to be something that is accessible to the advantaged and the wealthy. We want to make sure that it's available to everyone. Otherwise, we can't move the needle on public health. If we do that, are we helping to move the needle on health inequity just by virtue of doing that?
Well, first of all, I respect the role of science and technology in its many, many different forms. I certainly respect issues of geroscience and how to, as we used to say, promote the rectangularization of the life cycle so you can live up to 90 years old and 95 and still be on the golf course and feeling full of vim and vigor. And then you drop dead, but it's been a nice long rectangle. I mean, thinking in part, that's what increasing the health span is all about. And that is well and good. And yes, but here's my concern. First of all, to what extent is it something for the privileged? Something that's focused on those that can afford to be trendy to take advantage of it. For example, the village movement, which is very good. It's primarily middle income, non-Hispanic whites. It's a really good thing. So my first caution is, to what extent is it for the privileged and those that have the luxury to delve into all these really cool things? But to be honest, my greater concern are the existing inequities. The pandemic certainly brought out, if you're a low-income Black and brown person, you're going to be stuck in a household with several families. You're not going to have nutritious food, restaurants, and grocery stores in your neighborhood. You're going to have a tough time getting into a community clinic or an emergency room. Your kids are going to be forced to go to underperforming inner city public schools and all the greater vulnerability to the pandemic. I mean, we've got such basic foundational inequities that for many of our brown and Black communities, they don't have the luxury to think about, gee, how cool geroscience will let me be 95 years old and be on the golf course having a good time. So I applaud you. Focus on it to the extent there are real concrete accomplishments and tools that come out of that work. Then ask yourself, is it for those of us that happen to live in Palo Alto or in Santa Monica, in the really cool neighborhoods? Or is it also for someone in East Los Angeles or South Central Los Angeles? I mean, and that's my big concern.
Yeah, and Dr. Torres, I just want to put a little spin on this. And we have a conflict here. I don't think that simply by having the good geroscience and having it applicable so that we can live longer, healthier, we're going to create more equity in healthcare delivery. I think what Thomas feels is that if we are not as sick, then healthcare delivery differences won't matter as much because we won't need access to that. I'm more worried that we will not be able to have access to the geroscience that gives us that healthy longevity, because I have seen the inequities that you're talking about. And what we would like to do is make sure that everybody has the education to understand that those things do exist so that they can demand them in their own way. And so education is definitely part of it. And I want to throw that to you again, because without people knowing what is available to them, so it's back to your mom in that way. Without people knowing what's available to them, they cannot demand it, ask for it, or seek it. And I know that we need to message these communities all in different ways. What have you seen working in getting through to folks, not only getting their services delivered to them, but getting them to know that the services are there and wanting them? What's been working that you've seen?
Well, first of all, I fully subscribe, Adriane, to just what you're saying. And it's about making all this available in terms of both information and its application to the various communities. So to the extent that geroscience brings us these great, marvelous new things, yes, it has to be available and we have to know about it. Let me step back a second. There are two, I think, demographic trends that add urgency to support just what you said. The first, the 2020 census made it very clear the United States is already becoming a majority minority society, with Latinos and Asian and Pacific Islanders having the fastest growth rate, and they will be a majority in the years to come, with non-Hispanic whites falling below and becoming a minority. So we're going to be an incredibly diverse nation in the next 10, 20 years. The second is that actuarially, at least, ironically, Hispanics and Asians have the highest life expectancies. so there's a lot of reasons or questions about why actually they have the highest life expectancy, although the pandemic lowered life expectancy for everyone, but at least Latinos and Asians as a group. So the question then is, and this gets back to your point, how do we educate those that could potentially have a longer life expectancy that will be the majority of the population in this country, at least, to benefit from the very things that you're talking about? I have been promoting in our master plan on aging that we have longevity education in K through 12, to begin at the elementary, middle school, and high school level, just as we used to have education about Smokey the Bear and don't burn down the forest. And we used to have smoking cessation education so that kids don't start smoking cigarettes in middle school, which have been highly successful, by the way.
Yes, they have.
Now we need to do just what you're talking about. Bring that back to younger generations so that they can be socialized and begin to get it into their minds that these things matter. So I'm not sure what exactly we have now, but at least we're promoting longevity education, which can include many things you're referring to, but in K through 12 as part of the curriculum.
That is so important and so wonderful to hear, and something that we didn't know. We should be looking into that. This is one of the reasons these conferences are so amazing, because they become catalysts to what we can do and what we can offer to an educational and a school system. And I'm going to go down memory lane for a couple of minutes and then go back to Thomas, because this is really prompted by his question. You and I have something in common. We were born the same year, and we knew Maggie Kuhn, and we were there when the Great Panthers started, and we were there with Dr. Butler and so on. So we know the journey of the world of aging now. And of course, this has always been to bring equity to older adults, to live better after the age 65, to worry about poverty and medical bankruptcies. But there is a machine, and I'm going to call this the aging machine, the AARP, Leading Age, all of the nonprofit and profit organizations and government agencies that deal in aging, Department of Aging. Do you think that we can bring our message of healthy longevity into that group, or they are really invested in what happens to folks who are older? And that was prompted actually by Thomas's question. And I think it's a very good question, whether the world of gerontology in academia is open to thinking about this, because it's not quite a social issue. It's a social science issue. What's your feeling about this?
Adriane, you're referring to what Carol Estes from UC San Francisco once referred to as the aging enterprise.
Yes.
A whole industrial complex of folks that are invested now in their territorial benefits of being for old people, old benefits, old age benefits, et cetera, et cetera. And I'm now saying publicly, by the way, that we need to move away from the ageist system of benefit services and advocacy that we've created over the years. And certainly Maggie Kuhn and Bob Butler, who were my mentors, push for, although knowing them quite well, they never really meant that ultimately we'll do all things for all persons over a certain age and then ignore those underneath that. They never really meant that. They really were promoting intergenerational approaches and now interethnic, interracial approaches. But yes, we have created an enterprise that benefits from the current system of, whether it's AARP, the National Council on Aging, or whether it's benefits that you have to be 65 or 67 to qualify for. We need to begin to break those down, back away from it, and begin to find ways to open up, in this case, Medicare. It shouldn't just be for 65 and over. It should be a universal health care. Supplemental security income. It shouldn't just be for those that are older and very, very poor. We should have a minimum savings plan, minimum retirement income. I mean, there's so many things that we need to do now to broaden the availability of whatever public resources are necessary to recreate a social safety net. So yes, I would agree that we as gerontologists have promoted ageist solutions. Now we need to rethink where should we step back from that and begin to make them broader, more available, regardless of age. And that doesn't take away from the absolute need to promote gerontology and geriatric medicine and disciplines, et cetera. But it does mean that perhaps these programs that have been created that are quote unquote entitlement based upon age, we now need to rethink them, especially for the younger cohorts, whether it's Gen X, Millennial, or Gen Z. Yes.
Well, this was so, first of all, you definitely got that question exactly on point. It was a terrific answer. And I try to tell the aging community, look, you just have some new customers. So we're going to be very happy to hear you again this afternoon on our panel, large, wonderful panel, headed by an NIH leader on health equity and health span equity. And I'm going to throw this over to Thomas now, because he's going to be talking about the whole political scene. It's a series of sessions we're going to have now. So thank you so much. And I'm looking forward to seeing you soon in a couple of hours again.
Thank you all.
Take care.